gentlemen, thank you, Mark, for that wonderful introduction. Very kind. It's great to be back. I feel like I'm home here. In fact, I was here 6 weeks ago for your clubfoot course. And my wife keeps reminding me that I'm traveling too much. But how can I possibly turn down an invitation to come to Israel? I can't do it. So here I am. Mark has asked me to talk about some basic principles of deformity correction. So I hope I won't bore too many of you, but I think that a lot of the guys here are residents and fellows, so maybe this will be some use. In the end, I'll try to bring it together with the theme of the course. So let's first talk about traditional teaching versus current teaching. Traditional teaching in orthopedics, when I was a resident, we were taught that if you had genu varum, you had to do a high tibial osteotomy. If you had genu valgum, you had to do a distal femoral osteotomy. These were dogma. These were ingrained in our literature. But we're not in that era anymore. We're in a new era where the kids all have computers and iPads, and so we have to be much more analytical. So in this first example on the left is genu varum. Should we do a high tibial osteotomy or should we do what? That's what the traditional literature would say. The second case is genu valgum, and the traditional literature would say for genu valgum you should do a distal femoral osteotomy. This, ladies and gentlemen, is what I call the cookie cutter approach, that everything is make like a cookie, the same stamp. And that is really not the correct way that we should be looking at things. So I'll go through the system of analysis that we developed in Baltimore many years ago. We start with measuring the mechanical axis deviation, analyzing the joint orientation, and then based on that we pick the bone for the osteotomy. So there's a reason and a method to the madness. What's normal alignment? Normal alignment is when you stand up straight, your hip, knee, and ankle should fall in a straight line. So if you draw a line from the hip to the ankle, it should pass through the center of the knee. This is the ideal Vitruvian man. If you then want to delve deeper into it, you can draw a joint line, here the joint line of the knee, and draw an individual mechanical axis of the femur and an individual mechanical axis of the tibia from the center of the hip to the knee and from the center of the knee to the ankle. And then if you measure the angles that are formed by these lines, we see that in the knee, the lateral angle, the outside angle, averages 87 degrees with a range of 85 to 90. And the tibia also, measured on the medial side, averages 87 degrees with a range of 85 to 90. So now we have some specific measurements for the femur and specific measurements for the tibia. And based on that, based on this analysis, we can decide in a rational way if we want to do a tibial osteotomy, a femoral osteotomy, or maybe both. So here's an example of a patient I saw who had a high tibial osteotomy. And he was very unhappy because he's overcorrected. He's in too much valgus. And so what's the problem here? Is it the femur, the tibia? By doing the measurements, we see that he has an 87-degree femoral angle and a 98-degree tibial angle. Well, 87 is normal, 85 to 90. So the problem here is too much correction in the tibia, creating this unhappy patient. We know that when you do a high tibial osteotomy, you should never push them too far into valgus, but maximum 1/3 of the way from the center of the knee to the lateral side, the so-called Fujisawa point. So what do we do for this guy? We undid the high tibial osteotomy, put him just into the Fujisawa point, a little bit valgus for his medial compartment osteoarthritis, and he became all of a sudden a happy patient again. Here's a case of a 16-year-old boy who has genu varum and a leg length discrepancy. He had a growth arrest. So is it from the femur, the tibia? Where should we do the osteotomy? So we see he has medial mechanical axis deviation, 2.8 centimeters medial on the right. That medial mechanical axis, should we do, if it's varus, the literature would tell us to do a high tibial osteotomy. But when we measure the specific angles, we see that the real deformity is not in the tibia. The tibia is 85 degrees, which is in the normal range, but the femur has a 94-degree angle. Should be 85 to 90, so 94 is too much. And it's not a surprise that the femur is the problem because he broke his femur. So that points us to the direction of doing a femoral osteotomy. Here's a male with Ullier disease, and he has genu varum. Genu varum, the literature says high tibial osteotomy. Well, let's do the analysis. Well, he certainly has a lot of mechanical axis deviation, but when we do the individual bone analysis, we see that the tibia measures 94, a little bit valgus actually, not varus, and the femur measures 115, which is super mega varus. So even though he's genu varum, he needs a femoral osteotomy because the femur is the main culprit here in the disease. So based on this analysis, we choose to do a femoral osteotomy. Here's a man who has bilateral genu valgum and is starting to develop knee pain in his 30s. He's got 2 to 3 centimeters of lateral mechanical axis deviation, and his lateral compartments are starting to hurt. Well, the literature would tell us, valgus, you should do a femoral osteotomy, but let's do the analysis. We do the analysis of the individual bones, we see that the tibia, the femurs are normal, 87, 88 degrees. The normal range is 85 to 90. But the tibias are 93 and 95, which is beyond the normal. Normal is 85 to 90. So based on the analysis, the patient is pointing us towards the tibias, not the femurs. So is another example after example of how we make our decisions based on analysis of x-rays and not based on dogma. And to complete the analysis here, we draw a line representing the distal tibia, and the intersection between that and the femoral extension line is our apex of deformity. And that tells us where to do the osteotomy and how much to do the osteotomy. So in this particular case, we did it with an internal nail, first one side, and once that was healed, we did the second side. So you can see before, during, and after correction of the mechanical axis. Now what about this case? Overall, he's in valgus. This is a boy who got injured when he was 13, had a growth arrest. He's got a valgus deformity. And where's it coming from? Is it from the femur, the tibia, both, neither? What should we do? Well, if we do the individual analysis, we see that the femur angle measures 64 degrees. Well, normal is 85 to 90, so 64 is a lot of valgus. And the tibia measures 76 degrees. Normal is 85 to 90, so the tibia is actually in varus. The tibia is almost trying to compensate for it. So we have a mixed problem here. And neither one of these are acceptable numbers. And so in this case, the numbers would point us towards operating on both the femur and the tibia. So to delve just a little bit deeper, how do we do an analysis to tell us where to do the deformity correction? We have such a case this afternoon. Well, there's a method we call the 3-line method. You start with a line going through the center of the shaft. You then draw a parallel line to that going through the center of the head. And then from that blue dot, you drop a third line that represents a 6-degree angle. That line that we've drawn now is the mechanical axis of the proximal femur. Why 6 degrees? Well, if we look at the normal side, the difference between the mechanical axis line from the center of joint to center of joint and the femoral shaft line is 6 degrees. So we simply transpose that number to the opposite side, and that gives us a way of drawing the proximal mechanical axis. So now how to draw the distal mechanical axis, there's many ways to do it, but here for this case, I drew a joint orientation line. We know that normal is 85 to 90, so for various reasons I selected 90 on this one. So when I draw a 90-degree line to give us a normal LDFA, lateral distal femoral angle, we get an intersection point near the original growth plate injury. That's the apex of the deformity, and we can measure the magnitude. And now we can start to plan out our osteotomy. We want to do a 30-degree correction at that location. We can cut the bone a little bit higher because we need some room for fixation. There's also anatomic methods of doing planning. Won't go into all that in the short time that I have. And with either method, anatomic or mechanical, you get a similar result. And this is how we do the correction. And in this particular case, we used external fixator to get gradual correction in the femur and then a gradual correction in the opposite direction in the tibia. So in the end, you have a femur tibia that lines up so that hip, knee, and ankle fall in a straight line. How do we accomplish that? In this case, we used external fixator. That simultaneously lengthened and did angular correction in the femur and also in the tibia. And here's the before and the after. So all of these decisions are made based on a rational analysis of the deformity based on long-standing x-rays and careful measurements. So it's not eyeball, it's not art, it's not a sculptor, it's technical and it's science. So the message of this talk is if we are dealing with deformities of the long bones and we're trying to decide where to do the bone cut, which bone to operate on, My suggestion is that we use a very careful analytic approach to osteotomies about the knee and not a cookie cutter approach where varus equals tibia osteotomy and valgus equals femur osteotomy. I'll invite you all to come to learn what we talked about now just in the past 15 minutes in a 3-day course where we go through this very carefully, step by step, next August if you want to come. It's our annual Baltimore Limb Deformity course. Now next, to kind of bring this back to the main topic of this meeting, which is internal lengthening, I want to now describe another planning method that was devised by a German surgeon, Professor Baumgart, who designed the fit bone nail. And he does a lot of retrograde nails and retrograde corrections. So he designed something called the reverse planning method. And his original methodology was published in 2009, and it's done on long pieces of paper and moving them around. Why are we even concerned with this? This is a paper that we published in 2012 about lengthening of the femur, and this is very apropos to the topic. When you lengthen a femur with an external fixator shown on the far side, you align the fixator with the mechanical axis of the femur, which is not the anatomic axis. Why? Because in the end, we want to preserve the mechanical axis, not the anatomic. So the lengthening direction should be in the length of the direction of the mechanical axis. However, in the modern era of internal femoral lengthening rods, we put our rods in not along the mechanical axis, we put them along the anatomic axis. And so what happens, in the far diagram, you can see before and after lengthening along the anatomic axis, what happens to the knee. You are valgusizing the knee, you are shifting the knee medial, and so you are creating a lateral mechanical axis deviation. And Rainer Baumgart was not willing to accept this, and so he devised a way of doing a distal correction and nail insertion in such a way, and that's what I'm going to show you now, how that can mitigate this problem of the valgusization of the knee. So this is a summary of his method. I'd like to go through it step by step because we've modified the method just slightly so that we can use it on an iPad for a digital correction, so you don't have to use long 3-foot lengths of paper. We've shown in a previous publication that the Bone Ninja app, which we developed in our center and is available online for the iPad, is equivalent to PACS in terms of measurements of length and angular corrections. So this is an example of a distal valgus deformity and shortening. It's a 3-centimeter shortening in distal valgus deformity. So we start by calibrating the iPad, and then we do the usual steps of our analysis, measuring the mechanical axis deviation and analyzing the joint angles. So in this case, when you draw a line from the hip to the ankle, it's in valgus. When you draw the additional lines to represent the knee, and the green lines represent the mechanical axis of the femur and the tibia. Now we measure the angles. We get a tibial angle of 89 degrees, which is normal, and a femoral angle of 79, which is abnormal. It should be 85 to 90. So what this is telling us is the femur is the problem. The femur is also the short bone, so it makes sense. And so we're going to focus on the femur, and we're going to do a correction in the femur. Now, we can also do the specific analysis of the femur, which I went through before, the 3-line technique or the anatomic method, doesn't really matter. And what this points us towards is that the deformity is in the distal end of the femur. In this case, it measures 9 degrees. So we have a 9-degree valgus that we want to correct, but we also want to lengthen. We want to make sure that when we lengthen, we don't recreate valgus. So how do we do that? This is just the mechanical axis planning to show us that the apex is in the distal femur. So what we get down to, and this is the real meat of the reverse planning method, is we start by defining the new mechanical axis. So we know we're not going to operate on the tibia, so we extend the tibial line up, and that red line represents the mechanical axis of the new leg. In other words, when we're done, we want the femoral head to be on that red line when we're finished. So we start by drawing that line to represent the distal mechanical axis. Next thing we do is we draw a mid-diaphyseal line in the femur, and this is along the pathway of where a nail would be. And then you extend that line, you'll draw a second line, we call it a collinear reference line or a nail line, different color, and that's going to represent the pathway of the nail. The next thing we're going to do is locate the hip center. So we put a dot on the center of the hip. And the next thing we're going to do is decide how much we want to lengthen. So based on this x-ray, we want to lengthen 3 centimeters. So we'll go up 3 centimeters and draw a transverse line at that level. And that's where the new hip is going to be. Notice we want the hip center to move to that intersection point, 3 centimeters above the old hip and also on the red line. That's the goal. So far, very simple. The next thing we do is use the cut tool to perform the osteotomy. The osteotomy is performed, that's the white dotted lines. It's performed in the distal femur where you can get enough room for fixation, and that's near the apex of the deformity. And so we'll then take, with the Bone Ninja, and I can demonstrate this live if we have time, you take that piece and we move it over until the center of the head is at the new place where we want it to be. So we just basically translate it and raise it up until the center of the head is at the new place. Now the next thing we have to do is rotate that around the hip. So we take the rotate tool, which is that little thumbtack, and we'll put that up at the center of the femoral head and rotate the entire thing until that the femoral anatomic line passes through where our nail would enter in the knee joint. And this is our correction. Now that's what it's going to look like when we're finished, when it's all lengthened and realigned. But in surgery, that's not how we're going to leave surgery. We're going to leave surgery with it short. So we're going to deselect the proximal line and shorten it back down to where it starts. And this is how we're going to leave surgery. We're going to leave surgery with the femur in this position. So hip, knee, and ankle are lined up. And the nail is going to be inserted through the usual place in the notch and going up the shaft. And then if you move this up and down, you can demonstrate the lengthening. So this is how we leave surgery. This is the plan that we'll make a copy of this, put it on the wall, and when we leave surgery, we want to have a little bit of translation plus this amount of angulation so that the hip and knee and ankle line up. That's our operative template. We can then insert a nail into that and use this as a template as well. And it's nice on the iPad, you can play with this, make it go up and down, and recreate the correction. The last thing you have to think about is blocking screws, because you want to maintain this alignment. So you have to think about putting in some screws next to the nail that'll prevent it from shifting back to the previous location. And this gives you the predicted end result. So it's actually, it looks a little bit complicated, but if you do this a few times on the iPad with a case, very quickly it comes together. And I think, Christoph, you use this method in Austria. Christoph was trained by Baumgart in the fit bone and then converted that information to the precise nail, which was what we're going to be talking about today. So it's 9 o'clock. I still have 10 minutes, time for a demo? Okay, so Menachem, just to make this just a little bit more interesting, I'm going to, live demos are always dangerous, because something could go wrong. But, Steve Jobs knew that, and he practiced them endlessly. So what I have, I've hooked up my iPad. And this is actually the same case. It's not the case we're doing this afternoon, but it's the same case I just showed you. Oops. Okay. So this is the case that has a valgus distal femur and shortening. So I won't go through the analysis of the deformity. It's the same case that the apex of the deformity is in the distal femur. But so we'll start by drawing a line that, because we're not going to change the tibia, a line that goes from the ankle to the knee. And we want the new hip to fall on that line. So that's the first thing we do. Second thing we're going to do is we'll draw a line that represents the shaft of the femur. That's the anatomic axis, and I'm going to draw another line right on top of that one, actually. Right on top of that line, I'll draw a second one, basically coincides with it, but a different color. And that line should come out beyond the knee, and it works better that way. Okay. Third thing I'm going to do is take the dot tool and put a dot on the center of the head. If you don't like where you put these things, you can select them and use this nudge tool to move it a little bit till you like it. So that represents the center of the femoral head. The next thing I'm going to do is use the cut tool, that's this scissors, and I'm going to do my osteotomy at this level, and I'll trace out the proximal femur. Try to make it look like a femur here. Okay, so each one of these is an object on the iPad, and now I'm going to start the planning. So first thing we're going to do is group some of these things together. So I'm going to take the femoral lines, I'm going to take the femur, and as I select things, they turn blue, robin's egg blue. So I selected all these things, and now I want to do a lengthening of about 3 centimeters. So I'm going to move this object medial until the femoral head is on the new line, and also lengthen it by about 3 centimeters. So let's say we'll do something like that. That's our lengthening. Next thing I want to do, because we obviously don't want the femur to be there, I'll take this tool, which is the thumbtack tool, the rotation tool, put it on the center of the head, and then use that to rotate everything until when? Until my femoral line goes through the insertion point in the distal femur, where the nail is going to be. So right about there, the nail is going to enter at that point. So this is what it should look like when we're finished. Hip, knee, and ankle fall in a straight line. Now to demonstrate, we're not going to leave the operating room like that because we don't leave with an acute 3 centimeter lengthening. So now I'm going to take this entire unit and shift it down. And you notice how the femoral head is just falling on that red line. I can shift it up to simulate the lengthening, and I can shift it down. So when we leave the operating room, we want to leave the operating room with a picture that looks something like this. This is our goal. Now, when Rob is doing the surgery this afternoon on this very similar case, we're going to put an X-Fix on so that it lines it up exactly like that. And here we can, just to demonstrate what it's going to look like, we can select a nail. And so I've selected a nail. We'll put it in retrograde. And we're going to put it in so it's along the purple line there. So it'll look something like this. And Rob will probably want to put in some blocking screws. So just to represent blocking screws, I'll take the dot tool and we'll put a screw maybe here, maybe here, maybe you can put one on this side as well to maintain the alignment. And that, ladies and gentlemen, is the reverse planning method. It's described by Baumgart, but modified for the iPad. Thank you very much. Eitan.
Thank you. Let's say I'm doing my planning according to second rule of osteotomy, where your osteotomy is a different level of the core and you need translation between.
Yep.
Do you get a different planning result from that method?
No, for in this example, I did my osteotomy at a different level. The apex of the deformity is more in the epiphysis. So I did what you described, and that's why you see some acute translation in the result.
Can I plan it on this, based on this assumption, not,
Yes.
not a full reverse planning?
Yeah. Well, I mean, the beauty of the reverse planning method is that it ensures that when you're finished, you're going to be straight. You know, even if you took a normal femur, let's say we want to do a planning for the normal femur. If Baumgart was doing a retrograde lengthening of a normal femur, no deformity, he would still do the reverse planning because he wants to make sure that when he finishes, he doesn't valgusize it. If you just take this femur and shove a nail in either integrate or retrograde, you're going to get a little bit of valgus. Now, you could argue that the amount of valgus you get is not that much, and maybe you're starting in a little varus, or maybe you get a little bit of varus tilt through your osteotomy, so that does the valgus. So you could have all different kinds of arguments, and not everybody uses this method or these considerations for every case. But I think, if you're doing big lengthenings especially, it's important because, for a 1 centimeter, 2 centimeter lengthening, you're not going to create a lot of valgus by lengthening along the anatomic axis. But if you're doing a 5 or 6 or 7 centimeter lengthening, then you can truly valgusize. So I think it's just another tool in your toolbox. Yes?
You have obligatory translation here. Do you find it sometimes for technical reason as far as the diameter of the nail have to compromise for the angulation? Because the nail just won't go through.
Right. So there's a lot of, good question, there's a lot of other factors besides just the pure geometry. The diameter of the nail and the stiffness of the nail makes a difference. And actually, I left that out, but there is an article that talks about that when you have these smaller diameter nails, like 8.5 diameter nails, which are available in the precise 8.5, 10.7, and 12.5, the small ones are a bit flexible. And as you lengthen, they can bend. And so all bets are off. So it is always better. I try, whenever possible, to use at least a 10.7 nail because it's stiffer. And if possible, in a big person like myself, I'd use a 12.5 nail. Any other questions? Okay, so I hope I didn't confuse you all. It's not like you have to do this to do your first precise case. You can just put the nail in, the piriformis fossa and go. And honestly, that's the way I do a lot of my cases. And a lot of my cases will have distal deformities. I'll do a straight lengthening, and then later on, when I take the nail out, I'll do a distal realignment osteotomy. There are some disadvantages of going through the knee and doing a retrograde lengthening. It's a little bit more strain on the knee, a little bit more difficult rehabilitation, range of motion of the knee, and so forth. So sometimes we ignore all this, we just do a straight lengthening, and whatever valgus we create, we uncreate when we do the distal deformity correction.